Hi, I'm Sharrie Harlin-Davis, program host for Reid Beside You. And today we are discussing preventing sepsis. And with us today is Dr. Jennifer Bales. And welcome, Dr. Bales.
Oh, thank you.
Tell us a little bit of how your background and how you came to Reid and what you've been doing since you've been here.
Oh, well, I am an emergency physician and I've been here for, over 17 years. So just trudging away in the ER through COVID and all that.
And so I'm sure that's been very interesting.
Oh, certainly.
To be right at the forefront of the COVID. So hopefully it's calming down a little more for you.
I hope so.
Well, today we want to discuss preventing sepsis.
Very important, yes.
And we're talking about, this is Sepsis Awareness Month. And so what is sepsis?
So sepsis is the body's extreme reaction to infection. It's kind of like almost an angry overreaction, and it can be in response to infection, any kind of infection really anywhere in the body.
Okay. And there's a lot of statistics involved with sepsis.
Well, yeah, so it's fairly common. There's over, I believe, 1.7 million cases of sepsis every year. Significant morbidity and mortality. Over 270,000 deaths a year are attributed to sepsis. So it's very serious.
And a lot of times people assume that you hear sepsis and if they've been in a hospital setting, but actually it's kind of the opposite.
Oh yeah, sure. Most cases of sepsis, well over 80%, start outside of the hospital.
And so is sepsis contagious?
So sepsis is not contagious, sepsis itself at least, but sepsis is in response to an infection, and some infections can be contagious. You think about those. I mean, sepsis can be from really any kind of infection, so bacterial or viral or fungal, and certainly we know that many viral infections are very contagious, but sepsis itself is not. It's that body's response to infection.
So when we hear sepsis, and we're saying the causes, the different infections.
Oh, sure. I mean, it can be from anywhere. So you can get an infection in the lung, for instance. And we think of probably the most common would be pneumonia, but there are certainly other lung infections. You can get infections in the GI tract, like appendicitis or diverticulitis that can lead to sepsis. In the urinary tract, like a kidney infection, like pyelonephritis, or in the skin, like cellulitis, or a very aggressive skin soft tissue infection like necrotizing fasciitis. So all of those can lead to sepsis in any individual.
So it doesn't often just people hear sepsis and they necessarily don't know of how the infection started, but it's, they were in the hospital a while and then they have sepsis. And are you saying that often that's just when you're in the hospital and they're able to diagnose it better?
Yeah, so I mean, lots of infections are treated very successfully out of the hospital, but when things get worse, that infection's not getting better, or you start to have that extreme response, that's when you need hospital care. But most of the time that started prior to coming to the hospital, and we were able to identify it and start appropriate treatment.
Then, so who are the people that are at risk?
Well, so like many conditions, the people that are most at risk are those of the extremes of age, so over the age of 65 or under the age of 1. Also those with chronic medical conditions, certainly like diabetes or chronic kidney injury or cancer, and then also the immunocompromised and people who've had sepsis before.
So it's possible if you had it previously, then it can come back? Well,
sepsis is pretty serious, and so if you end up in the hospital, you often end up with some chronic medical conditions after that, and then just having had sepsis before predisposes you to getting it again.
And you were saying with more in the elderly, because they have more...
more chronic conditions generally, and then also are just more susceptible to infection, and their immune systems are not typically as ready to go as someone who's, say, in their 20s.
And then there's some different signs.
Oh, yeah. So
and the symptoms for sepsis.
It's important to know the signs and symptoms. So what you're looking for when you're trying to figure out if you need to seek help or if you're at risk for sepsis is, fever, right? And the shaking, rigor, chills that goes along with that. That's probably your most common symptom of infection is fever. but then also really high heart rate, which might be evidenced by heart racing or palpitations, also low blood pressure, which might feel like being lightheaded or very, very weak or even passing out. You're also looking for those really severe symptoms like shortness of breath or confusion and disorientation. And then really extreme out of the ordinary pain is an important sign as well.
And all of those things that you'd mentioned, the shortness of breath or the fever or the high heart rate, it mirrors so many, maybe a heart attack or with the
certainly.
infection. So.
Yeah, sepsis is not as easy as it sounds to diagnose. A lot of those symptoms can be signs of other things as well. But if you have those concerning symptoms, you need to seek care from your medical provider to help you tease that out. Is it sepsis? Is it something else? And start appropriate targeted treatment.
And if you're seeing a patient and then you mention that they do have sepsis, so if a patient thinks that it possibly could be sepsis, what are some of the things that they should do?
Well, so if
especially get the medical care,
well,
we know that.
Right. Well, if you have mild symptoms, right, it's appropriate to seek care through your primary care provider or the urgent care, even a telehealth option. But if you have severe symptoms, particularly those symptoms of confusion or disorientation, shortness of breath, very high heart rate, very low blood pressure, it's appropriate to seek care in the emergency department and always, of course, in an emergency, call 911.
I would think that you would have to act, especially in that situation, often in a chronic care situation, the person that comes with you, the caregiver, a possible caregiver, or would you also make sure that they are involved in knowing what to look for?
Yeah, I mean, those signs and symptoms are always important for yourself and your loved ones, of course.
So to make sure that they are that they're aware, because often in those situations, the person might, especially if they're feverish, well, they might not have paid attention.
Yes.
And then the caregiver can relate.
Well, or they've become confused, right? A lot of times people are, in denial about some of their symptoms. It's always that family member that said, no, you've looked short of breath when you're moving around and you're not acting like yourself. And those symptoms are important.
So that's always, I'm telling the public, we're always trying to make sure just some common things that they should look for.
Yeah, absolutely.
So that's always great. Can you give us an example of a case that you've had a sepsis patient come in?
Oh, well, I mean, it's relatively frequent that we see it in the emergency department. So a very common example is an older person that comes in with fever and they've become a little bit confused, that heart rate is up, and they've been having maybe urinary tract symptoms like burning with urination for a while that they've kind of been ignoring, and now things have reached that critical point. And, it's always better to seek care earlier, but we do see that a lot.
And I've noticed that, and I deal a lot with seniors in the community.
Yes.
And they have a lot more urinary tract infections. Is there a cause for that?
Well, there's a lot of things, right? There's that reduced immune response as you get older. It's more difficult sometimes to manage your hygiene. It's a multifactorial issue for sure.
But it's not something that you need to be ashamed of or
certainly
something
not.
like that?
Certainly not. And you shouldn't ignore symptoms. If you have mild symptoms, it's always better to get treatment earlier.
When we're looking and seeing other patients, I'm going to ask for another example. So maybe if they had possibly like a heart problem, would you see that? Well, actually, on a personal note, we had the last time I was supposed to interview you, I had pneumonia.
Oh.
And
Oh, no.
so
Yes.
it didn't go to sepsis, but I do remember that. And
I think I was talking about influenza at that time,
Right.
which is a virus that can
Yes.
cause sepsis. Absolutely, yes.
And it was pretty interesting because we were supposed to tape. And I ended up in the emergency room.
I'm so sorry.
And it's like, oh, so
Yep.
you're Dr. Bales. Okay.
Yes, that's right. That's right. I'm there a lot. Yes, absolutely. Well, yes, certainly pneumonia is a common cause of sepsis. You think about pneumonia as fever, cough, and shortness of breath. You can have pneumonia and not have sepsis, but it is one of those infections that can lead to sepsis.
And it's very interesting that I remember someone said that you were with this it could take a longer time to recover. And it did take a longer time to
Yes.
recover. So I can see how the infection and sepsis could actually set in. So
Oh, yes, yes.
the and also, how would, if someone normally, because you're in the emergency room, but and if somebody just needed to meet with you, is there a way that they can communicate with you outside of the emergency room, or?
Well, so I only work in the emergency
Okay.
room, so I'm there for you someone's in the emergency department for you there 24 hours, 7 days a week. But, there are lots of ways to communicate with your primary care medical provider. There's always urgent care resources and telehealth options too.
So great. Well, we want to thank you for joining us today.
Oh, thank you for having me.
And so this end, we want to recognize Sepsis Awareness Month. And thank you for joining us, Dr. Jennifer Bales.
Thank you so much.
We know this legendary institution. They have 3 goals: pain-free, quicker recovery, and shorter hospital stays. Here are your doctors of Reid Orthopedics. The eviscerator of pain, Dr. Chris Nair. Dr. James Bones Natal. The Wizard of Wall Street, Dr. Mario Lee. The talent, Dr. Joel McClure. This team, this care, this treatment. The doctors of Reid Orthopedics.
Welcome back to Reid Beside You. And we are now joined by Joy Bowlin, Nurse Practitioner Cardiology from Reid Cardiology. Welcome.
Thank you, Sharrie.
And we are going to talk about atrial fibrillation, also known as A-Fib. And also, Joy, tell us how you came to Reid.
Well, I have a background in cardiac nursing at Reid, and I've been with Reid for about 18 years. I started out bedside nursing on the cardiac unit and then worked in the cardiac cath lab and the electrophysiology lab, and now I've been with the cardiology practice as a nurse practitioner for just over 4 years.
So you're a staple in cardiology.
Trying to be.
So what is A-Fib?
So atrial fibrillation is an irregular heart rhythm, and this is where the top chambers or the atrium, they beat out of sync with the lower chambers. For a lot of patients, they'll have a rapid heartbeat, but it's an irregular heart rhythm, and there's several different risks associated with that, one of which is the main topic of conversation is A-Fib increases your risk of stroke.
So, and do people have any type of symptoms or?
That's a great question because some patients are very symptomatic and they will experience things such as heart palpitations, like irregular heartbeat, more fatigue, shortness of breath, sometimes chest pain, lots of different symptoms. And then there's other patients who are completely asymptomatic and totally unaware that they're having atrial fibrillation.
And so should they receive regular checkups or what's the best?
Yes, definitely routine screenings with your physician or, healthcare provider just for routine, every general healthcare workup. Sometimes it's found incidentally. We have a fair amount of patients that will come in, to the office or to the hospital and it was completely an incidental finding. They went to their primary care provider, for just a routine checkup, and they said, hey, you have an irregular heart rhythm, did an EKG, and they've been diagnosed with A-Fib. And so it's more common than what people would realize to be walking around with this and not know that they have it going on.
So often if you're watching a television show, you might see, and the person had no signs of anything, and you see the irregular heartbeat.
Yeah.
So that is very common then.
Yes.
Mm-hmm. And they also could feel retired.
Yeah, sometimes people will have just kind of a vague, complaint of like, the last few weeks I've just been feeling more lethargic, more tired, not myself lately. And sometimes that can be one of their main symptoms.
And who's at risk?
Well, men and women. So, sometimes we think of cardiac problems as being more male specific, but actually it impacts women as well. And patients as they age, this is definitely a disease that we see more often in the elderly. And so our older population, which is an ever-growing population, is more and more common. It's estimated that over 12 million people in the United States will be living with atrial fibrillation by the year of 2030. So it's very common. And also patients who have other health conditions, sleep apnea, obesity, other heart conditions, any type of illness that increases inflammation in your body. Some of those like chronic conditions also make patients have higher risk for atrial fibrillation.
One of the signs said drinking alcohol.
That's a good point. Yeah. So alcohol, unfortunately, is arrhythmogenic. It tends to trigger arrhythmias, and atrial fibrillation is very commonly seen. In fact, we kind of have a term for that called holiday heart, because a lot of times after the holidays, people have had a little more drink than they usually would. Increased alcohol correlates with increased, incidence of atrial fibrillation.
And family history.
Yeah, sometimes patients will have a familial history of A-Fib as well. It can be a contributing factor. But don't rely on that entirely, because many patients have no previous, or perhaps they had A-Fib in their family that was undiagnosed, but it's not something that's specific just to like a family history.
Okay.
Yeah.
Then there's also an option for A-Fib.
Yeah, an alternative treatment option. Yeah.
Okay.
So to be clear, what we're going to talk about today is a treatment to help minimize your risk of stroke. So there's different ways of managing atrial fibrillation as far as if patients are symptomatic and how we handle that with medications and treatments and that sort of thing. But this option is specifically in relation to the stroke risk for A-Fib. So patients who have atrial fibrillation, because those top chambers are beating rapidly, chaotically, it increases your risk of blood pooling in those chambers. And there's one specific area where blood tends to pool and can form a clot and can leave that area and go to the brain and cause a stroke. And so the Watchman device is our topic today, and this is an alternative to being on long-term anticoagulation or long-term blood thinner. So many patients who have atrial fibrillation will be prescribed a blood thinner, something such as like warfarin, Eliquis, long-term. Xarelto is another one of the common ones that we use. And this is to help to minimize the risk of stroke. Unfortunately, when you're on a medication that's purpose is for blood thinner, it also comes with increased bleeding risk. And so then, we have this challenge a lot of times with patients of, which risk is higher, your risk of stroke, your risk of bleeding. And so the Watchman has come along and been really a great alternative for patients. It's a small device that's actually implanted in your heart. And this is implanted in the area where most of the blood clots form. And it's an alternative to being on a blood thinner long term. Typically, patients who have this procedure, they do need to be on a blood thinner short term, usually for around 45 days following the procedure. And there's kind of a step down protocol. Eventually, they are recommended to be on lifelong aspirin. But the goal is to help to protect them against stroke and to get them off of the blood thinner. And we've got a little slide up here, I believe, that actually shows you where the Watchman device is placed in the heart. So the top left chamber, there's a little pouch-like area that comes off that top left chamber. It's called your left atrial appendage, and that's where more than 90% of the clots form that then go to the brain and cause a stroke. And so the Watchman device is a small device that's implanted right in that area to kind of seal off that left atrial appendage to help to close that area so that clots can't form there and cause a stroke.
And it's very small.
It is small, yeah, but it's a small area that can cause really big problems. So it's very important for stroke prevention.
Who are what can patients expect?
What can they expect? Yeah, so the initial workup, obviously someone has to have a diagnosis of atrial fibrillation. So there's patients who are on blood thinners for other reasons. Unfortunately this doesn't fit every kind of problem, but for patients who have atrial fibrillation, it's an option for them. So they have to have the diagnosis of atrial fibrillation. Most of them are probably seeing a cardiologist if they have known A-Fib. And then we have a risk scoring that we look at, so risk of bleeding. A lot of our patients actually come to us after they've already had bleeding problems. So they've been on a blood thinner for, years or however long, and then they've developed some kind of major bleeding, or patients that have frequent falls, dizziness, increased risk of having, trauma and bleeding, that sort of thing. And then some patients, they have heard of the Watchman, and so they will come to us and say, hey, I'm concerned about being on a blood thinner long term and the risks that are associated with that, and I would like to have a different option. So usually they get referred to cardiology if they're not already seeing us, and then they will see one of our physicians, kind of evaluate things, see if they're appropriate candidate. There's kind of a workup process because, as we talked about, that left atrial appendage, that area, Everyone has one, but it has a little bit of different size or shape for each patient. And so they need to do some imaging studies to look and make sure that, if you were to have a Watchman, to make sure that you would be an appropriate candidate. And so they do something called a TEE to get measurements specifically of the left atrial appendage, look at the size and the shape, make sure that it's appropriate, that it could accommodate a Watchman device. Fortunately, the Watchman devices come in multiple sizes, and they've actually become even better over time as the manufacturers have updated, the type of device for specific patients. So most patients, as far as from that aspect, just a size aspect, most patients would qualify, but occasionally people might be an outlier that they're not an appropriate candidate.
So it's not a new procedure.
No, I mean, in comparison to some of the procedures and techniques we've had, it's a newer procedure, but we've been doing it for years now at Reid, and we've had a lot of patients that have, had great outcomes being able to get off their blood thinner because of having the Watchman put in.
Is it something that once it's in, do they have to continue to return, or?
So once it's in, it stays in place. It's not something that really needs like routine monitoring after the initial phase. So when you first have the procedure done, you would see us back in the office for follow-up, usually within like a week or so. And then roughly at about 45 days, they do another repeat TE imaging study to go in and look and make sure that everything has been sealed appropriately with the Watchman device in that area that it's placed in. And for most patients after that, roughly about the 45-day mark, they're able to get off of their anticoagulation, and they kind of step down to a different medication regimen. They're usually on a medicine called clopidogrel or Plavix along with a baby aspirin until they hit the 6-month mark after having the Watchman procedure, and then most of those patients will go down to just a baby aspirin at that point. So we see them quite frequently, kind of initially in the workup. We see them getting things planned, lined up, having the procedure, see you back, have a TE, and then after we see them back for like that 6-month follow-up, we kind of cut them loose, and we just see them infrequently after that.
So then it turns into more of a maintenance.
Yeah, then it's just kind of, it's not something that we have to keep seeing you back and scanning you and things like that. It's just the workup process.
I'd like to hear success stories. So could you give me an example of?
Yeah, I can. So, a lot of the patients, like I say, that I see, they have unfortunately already experienced, major bleeding. And so they're high risk. And so we'll see them back and, have this procedure done, eventually get them off the blood thinner. And then, just being on a baby aspirin in comparison to another stronger anticoagulation, much lower bleeding risk. But I can think of one patient that comes to mind that I think was, a pretty kind of wow moment, is someone who had been on anticoagulation for at least a few years because of having atrial fibrillation. So they had been on this for stroke prevention, and this patient had a Watchman procedure and went through the protocol and was able to come off of anticoagulation and was just on a baby aspirin. And somewhere, maybe like a year or two later, this patient was involved in a very serious motor vehicle accident. And I mean, it was life-threatening injuries. Unfortunately, survived that. But I remember seeing them back later, down the road after that, and it was like, oh my goodness, had you have been on anticoagulation, a blood thinner, with that kind of trauma, it would have really complicated things even further. I mean, most likely that patient probably wouldn't have survived. And so I thought that was kind of something kind of outside the box you don't think of every day. But even with that, the risk of being in an accident or something happening, not being on a blood thinner long-term can have a huge impact.
That's really interesting. So I'm sure that we know that during the Watchman is not a new, but that you've been here long enough that you've seen the growth in using certain techniques and processes. Yeah. So that must be really interesting.
It is, and I feel like it's really become much more common now, and I feel like, the amount of patients that we see, we're kind of even touching the tip of the iceberg. Like, I think, initially we were really aiming on the high-risk people, the people who have had major bleeding and things like that, but, other patients, they're in like, they have higher risk occupations, maybe something that they're higher risk for injury or trauma, and then being on a blood thinner increases their long-term risk of bleeding, And there's a lot of patients out there, and I think just kind of getting the word out that this is an option, to help to treat you, to minimize your stroke risk and get you off of a blood thinner long-term, it's a good choice for a lot of patients.
Sometimes the blood thinners are pretty hard on the body.
Well, it certainly increases the risk of bleeding, yeah, for sure.
Yes. Another thing, as we're moving into that, and when they do come back for their success stories, what's some of the responses to you?
Well, I think a lot of times they're just, they're just grateful to be able to not have that worry on their mind of being on a blood thinner and what if this and what if that, And some patients, like, prior to having the Watchman, they had recurrent hospitalizations because of having bleeding and having to get blood transfusions and things like that. Or other patients maybe had recurrent falls, and risk of head trauma and things like that. And so I see a lot of them, they're really grateful, And something else I think sometimes people don't think about too, as you get older, there's other things in your body that have problems too. And so a lot of times patients who have been on, a blood thinner long term, then as they get older, they have something else come up that, say you need to have like surgery. And if you're going to have a major surgery, a lot of times you have to also hold your blood thinner medication prior to that to reduce your bleeding. And, in that window, while you're holding your blood thinner, sometimes stroke can occur. And I've seen patients where that has happened, unfortunately for them. They had to be on a blood thinner and then they were holding it because they needed a procedure. And so, once you have the Watchman, it's there, for the rest of your life. You can just take a baby aspirin. And so, it's a great long-term, like peace of mind long-term, I think.
Well, that's great. Also, now if their primary care physician had referred their patient to Reid Cardiology, how can people reach you?
So Reid Health Cardiology, I believe you guys, you have the address and phone number and everything up there. Yeah, they can refer patients, anytime they see someone that has atrial fibrillation, if they're not already following with cardiology, we would love to see them and talk about further treatment options.
Well, great. We want to thank you, Joy, for joining us today on
Thank
Reid
you.
Beside You.
Thank you very much.
And thank you for joining us on Reid Beside You.